Good evening to one and all assembled here, and this is going to be a talk on urodynamics in children, um, mostly on the practical aspects of urodynamics and how to understand the urodynamics and how to understand the principles of urodynamics. This is going to address a different set of audience, a bit of juniors as well as seniors. So there will be some basic level urodynamics as well as some advanced level urodynamics. So urodynamics in children is a little complex topic for everyone to understand, and the principles of urodynamics in children is pretty much same as in adults. And I will talk a little bit about the basics of urodynamics and also on the practical aspects of the urodynamics, the troubleshooting, then how to interpret some of the urodynamic curves. So what I would like to start is with the indications of urodynamics, and there are different types of urodynamics. First, you understand there are different types, and then cystometrogram is a filling phase study where you essentially look at the filling phase of the bladder. Pressure flow study is a filling and voiding phase study. Video urodynamics is where you instill contrast and also do a screening, and sometimes you may be able to capture the urodynamic image of the bladder in the graph itself with special advanced software. And the provocative urodynamics is where you occlude the bladder neck and try to overcome the bladder neck incompetence. And the uroflow EMG is a type of urodynamic where you look at the voiding phase. So what do we look for in urodynamic examination? Bladder has got two functions, storage and emptying, and ideally both should be assessed during a urodynamic examination. So during the storage, is the bladder relaxed during the filling? Is the capacity adequate? Is the sphincter competent during the filling, which means there is no leak? And if there is a leak, whether it is due to the bladder component or sphincter component, and those things we need to understand and identify. During emptying, what we look for whether the bladder contracts adequately, generating enough pressures to void, and whether the sphincter is relaxed in sync with the contractions, and whether there is any retrosor sphincter dysynergia, and whether the emptying is complete, which means whether there is any post-void residual volume. When to ask for a urodynamic examination, it is essentially to answer a specific clinical question, like whether bladder is that a reason for the problem the child is facing, like persistent hydronephrosis, or the leakage, the wetting, or the increasing creatinine in a patient with a posterior urethral valve or a neurogenic bladder. When the results of the test will decide the management, like whether you're going to add an anticholinergic or a clean intermittent catheterization, then you ask for urodynamic. Then whether major surgery like a bladder augmentation is planned, and that is a real indication for urodynamics. And obviously before a transplant, one has to make sure that the bladder is stable, particularly in those with the posterior urethral valves and neurogenic bladders. So in them also, as a part of the transplant workup, the urodynamics has to be done. The typical indications for invasive urodynamics are neurogenic bladder. In children, it's usually post-myelomeningocele or sacral agenesis, and sometimes it can be because of following a pelvic surgery, like a pull-through surgeries. It can be due to a valve bladder, where the persistent hydronephrosis or raising creatinine, even despite the clearance of the posterior urethral valve, and severe forms of bladder dysfunction, like a Hinman syndrome, are indications for invasive urodynamics. It's typically not indicated in a child with bedwetting, which is essentially monosymptomatic nocturnal enuresis, and that is more of a disorder which doesn't affect the bladder. It is more to something to do with the brain and the antidiuretic hormones, so you don't really need urodynamics in these children. Milder forms of bladder dysfunction, obviously, you can try empirical treatment with anticholinergics. You may not need the invasive urodynamics. Isolated VUR, it is a controversial topic. When the bladder is normal on avoiding cystourethrogram, or when there is no history suggestive of voiding dysfunction, like a bowel bladder dysfunction or dysfunctional elimination syndrome, I personally will not do a urodynamics, although some people do a routine urodynamics in all vesicular reflex, which I think is a little bit of an overkill. I always ask for a bladder diary in children with particularly voiding dysfunction. If they are getting worse, then before doing urodynamics, I want to know the bladder diary, how whether they are leaking at what particular time, what is the frequency, whether there is any urgency, urgent continence, what is their intake. All those things I need to know beforehand, because if I can come to a diagnosis of an overactive bladder, for example, from the bladder diary, I may simply start them on some anticholinergics and then avoid invasive urodynamics. A typical indication for a video urodynamic is when you have a associated vesicular reflex or bladder diverticulum, or there is a lot of leakage. The urodynamics can be false normal due to these reasons. So these are the indications for video urodynamics. Unfortunately, this is not available widely. So I tend to get an MCU beforehand, and if the prior MCU shows that the bladder is normal, then there is no need for a video urodynamics. If it shows vesicular reflex, then you know that is going to alter your reporting. If somebody has got a bilateral vesicular reflex grade 5, then you probably have to report it with a pinch of salt. Even if the pressures look normal, you may have to think that the upper tracts are sometimes responsible for it. Now, patient preparation, urine culture is very essential, and active urinary tract infection is a contraindication for your dynamic examination. I always try to get a laxative before the night, and sometimes I may give an enema on the day of the procedure. Explain the procedure, get an informed consent. Parental antibiotic prophylaxis. Often a single shot of aminoglycoside is given. One should always check the creatinine levels if that is being given. Most of these patients may have a renal impairment. I always ask these children to void before the surgery, and typically I get it as in the form of uroflow. So they have to empty the bladder into the uroflow machine, so that we know what is happening during the voiding phase. In children particularly, at the end of the procedure, they do not void because of the trauma and then irritation. So it's better to get a uroflow beforehand. The principles of urodynamics are like we are measuring the pressure in the pressure of the detrusor. So the intravesical pressure is basically a combination of a detrusor pressure and the intra-abdominal pressure. So to identify the intra-abdominal pressure, we leave a rectal catheter, and then once we subtract the intra-abdominal pressure, which is a rectal pressure, we know that whatever remaining pressure is the detrusor pressure. So the equation is P detrusor equal to P vesical minus P abdomen, which is a rectal pressure. So that is how normal or stable bladder looks like. All three lines, usually the top line is the vesical line, the second line is the rectal line, and the third line is a detrusor line. Now, ready-made versus custom-made catheters. Typically, in children, we tend to get a 6 French or 7 French double lumen urodynamic catheters and ready-made rectal lines. In adults and older children, you can use 2 5 French feeding tubes. This may not be possible in a little children. Rectal catheter obviously can be custom-made in both adults and children. Only thing is to emptying and then adjusting the rectal pressure is a bit difficult without a three-way connector here. Here you can nicely adjust the rectal pressure. Now there are a couple of differences between urodynamics in children less than 5 years or neurologically impaired from the children older than 5 years or non-neurological patients or adults. In little children, we always tend to do the urodynamics in lying position, whereas in adults and older children, it is a sitting position. In little children, the leak has to be seen. You have to make sure that you are watching that area, whereas in adults or in older children, you can measure the leak in the uroflowmetry below. The capacity and the fill rate are pretty low in little children, and they can't tell the sensation. So the first desire, all those things, they don't tell. They just simply cry, and then you know that when they start crying, after going quiet, then you know that is the first sensation. And they do not void at will. So you cannot give a command to void like what you do in adults or in older children, and that is a problem in children. But when they have a full bladder, they cannot hold, so they automatically void. Then the uroflow again, the voiding phase is really not possible in little children because a 6 or 7 French catheter itself will take the entire urethra, and in addition to that, you ask them to void around it on the during the voiding phase. That becomes extremely difficult, and the crying activities and distress and being non-cooperative, a lot of artifacts are likely in children, and it is essential that you are available and the parents are available in the area so that you can deal with those things, and then make sure that what you are noting the artifacts. So that is about it. Now the child cannot be hanging to the toilet for life, so you have to make sure that the child has got a proper back support, arm support, and leg support. Now, starting the urodynamic examination, there are a couple of important things you need to note. Setting zeros is very important. The zero pressure is basically the surrounding atmospheric pressure. This you have to remember. The reason I put these arrows here is the zero pressure is the transducer is open to the atmosphere when you zero the study, not to the patient. So the patient is closed off. The second thing is calibration of transducers. You have to make sure that there are no air bubbles in the transducers, and the reference point is always the superior edge of the pubic symphysis. So if you are doing in a lying position, and then somebody has left it in a lower position for sitting position, then you have to elevate it according to the level of the couch, and there should be no air bubbles in any of the transducers or tubings. Coming to some points of quality control, the initial pressure is not zero. The initial pressure is something, the intra-abdominal pressure is there, so that is reflected in the bladder also. So the initial vesical pressure is something like 10 to 15 centimeters of water. So that is how it is, and that's quite normal to have initial pressure of 10 in the vesicle, maybe 10 in the abdomen also. That gives a subtraction of 0 to 1 in the detrusor. And you have to get a cough very frequently. In children, any crying or any activity, if they say a word, that can be considered equal to cough. Fill rate, in adults, generally they fill at a 40 ml per minute routinely, but this is not the way it's done in children. A slow fill is what is needed. A slow fill means something like less than 10 ml per minute, and usually the procedure is done over 20 minutes. So if there is a bladder capacity is 200 ml, then you have a 20 ml, a 10 ml fill, so that the procedure happens over 20 minutes. So the faster the fill, you will automatically produce a abnormal compliance. The fill rate is generally 5% of the bladder capacity, and the bladder capacity, there are different formulas. The what formula I use is the cost formula. It's age plus 2 times 30 ml. So if somebody is like 3-year-old, then that is 3 plus 2, 5, then that is times 30 is 150 ml. So that is how you record the bladder capacity. Now this is a case of posterior urethral valve. Classical dilatation of the posterior urethra. I've just had a little video of the valve fulguration being done there with the diathermy hook electrode. In this patient, after 3 months, there was a good resolution of the posterior urethral dilatation, and the valve is gone. But still, there is a persistent hydrouretronephrosis. And to find out what is going on with the bladder, we started using the urodynamic study. So this is a 2-year-old child. The capacity is like age plus 2 times 30 is around 120 ml. So that is the urodynamic study. That is the study being done. So each time the child is crying, you can know that this is causing a deflection. And this patient, we are taking the machine to the radiology department to do it in the form of urodynamic video urodynamics. So here we can see that there is a contraction wave is happening, and at the end of the contraction wave, the child has started crying, and then there will be a rise in pressures. I'm sorry, there is an overlapping activity of voice sound from the original study itself. So that is the original voice of the video recording. So so you have to watch for the urine, and then that is the screening being done, and you can see that the bladder is emptied, and that is the end of the study. Now this is another patient who had a myelomeningocele operated, and this is a 8-year-old, so the bladder capacity is something like 300 ml. So we start with uh, getting rid of the air bubbles, and we start with zeroing the pressures. Rectal line is being inserted. I cannot show you the insertion of the lines because of the fact that we cannot expose the genitalia of these children. So that is how the pressures are like. It is 15 to start, 15 to start. So subtraction is very good. It is 0. And we are using a 10 ml fill. So 300 ml capacity, 10 ml. So that's going to be taking half an hour's time. But often it takes less time because they have a lesser capacity. So always keep the capacity less than what you think. So in this patient, we have started a slow fill, and you can see that already the pressures have started to go up to 60, 70 of detrusor. It's a true deflection because the abdominal pressure has not gone up, but the detrusor pressure has gone up. And here we are doing a video study here, and here you can see that there is a reflux going on. There's a reflux, grade 5 reflux onto the left side. Despite the reflex, the pressure is going up. So this is a real bad bladder. And then sometimes in the presence of a bilateral reflux, you don't see the rise in pressures. You can see a good subtraction here. So you can see a cough, cough, and then there is a very little deflection in these lines. So a lot of reflux is happening, and then pressure is also going up, and that is a bad bladder. So the pressure has already, P det has already gone up to 60, 70 here. Now this is an older patient who is having urodynamic procedure done in a sitting position. So this is a patient who has a valve bladder. Well, in the sense he had a posterior valve, and the valve is now gone. He is now become 14, 15 years, and his creatinine has gone up, and then he is pre-transplant candidate on dialysis. So there's a good subtraction. This is like an adult, so he can cough at your request. And in this patient, so again, see, good subtraction is there when he coughs. The initial starting pressures are very low only. We see that as he progresses, there is not much increase in pressure. So the bladder is looking a little bit like hourglass. It's a large capacity bladder there, and despite that, he is not having any pressures. And then now he is voiding now. This is during the voiding phase. This is an older patient. Obviously, you can get a voiding phase. In younger children, you cannot get a voiding phase. So he voids a prolonged trace, and he is generating a very poor abdominal pressure. So this is a large capacity decompensated bladder, more like an atonic bladder. So it is in the third stage of a valve bladder, and that is a bad news. So he needs to go on a CIC. So why is it important to be there in the room watching the run? Now, sudden increase or decrease in P vesicle or P abdominal can be there due to movement, blockage, or catheter disconnection, crying, or straining. A smooth increase in P vesicle is usually due to an impaired compliance or a rapid fill, and smooth increase in abdominal pressure is usually due to a rectal contraction. So I will show you an example of all these things. So here, if you see, this is, as I said, the first line is usually the vesicle line, second line is the rectal line or abdominal line, and third one is the detrusor line. So here there is no contraction here, but there is a smooth wave here. So that is a rectal contraction, which is a positive reflection in the abdominal line, and correspondingly there will be a negative deflection in the P det. So you should not mistake it. So you should know a smooth contraction means something is happening. This is an acute contraction, that is a cough, and that has been subtracted nicely here. And this is a smooth contraction, and this is a wave which is happening in the bladder, and there is no contraction in the rectum, and that is being reflected in the P detrusor line. So that you have to understand. Looking at the graph, you should be able to tell which is a vesical contraction, which is a rectal contraction, and which is a cough. So the initial P det, as I said, is usually 0 to 2, and the initial, if the P det is really high at the beginning, then it can be because of low abdominal pressure or high vesical pressure. Similarly, if the P dot initially is very negative, it can be because of the opposite thing happening. The P vesicle itself is low or the P abdomen is too high. Now, if the P vesicle is too high, then you know that there is a kink in the catheter, or there's a contact with the bladder wall, or in the catheter, you have to reposition the catheter. If the P abdomen is too low, then you have to flush the rectal line and then make sure that this is corrected. So, in this patient, the abdominal pressure is very negative, so it is showing as a high P det, but actually, this is because the abdomen is not recording it. Similarly, if the abdomen is too negative, for example, in this patient, the abdominal pressure is 21, so the P det is going negative. So that is also wrong. So you have to make sure that the rectal line is generating proper pressure and it is more in line with the vesical line. So in this patient, if you notice, where is the P det line? So you can't see the P det line. The reason is because when they started, they didn't zero properly. So what has happened is the vesical pressure was like something like 30 or 40. The abdominal pressure was slightly higher than that. So the line was running below zero. It is running somewhere here. So that is totally, you can't see the P det line. So the most common mistake is setting zeros with the catheter connected to the patient instead of to the atmosphere. So this is a common thing which people do. So they connect everything to the patient and zero all. So 0 minus 0 is not 0. The reason being, if the pelvic floor relaxes after the starting of the study, like for example, in this, the pelvic floor has relaxed, so it becomes very high pressure. So if the abdomen becomes negative after the study, then it becomes too positive. So that is not a right thing to do. So you should have all three lines visible, and it should be something like 10 minus 8 gives 2. That is acceptable rather than not having the line at all. Another important problem people face is like the filled volume, it does not add up at the end. I mean, the filled volume, if you have filled around some 350 ml and the patient has voided 300 ml, then there should be a PVR of 50 ml. Now, what happens is sometimes the filled volume is only 250 ml or recorded as 250 ml, but patient voids 350 ml. So, where did the extra come from? So, there may be error in the filling, or it may be because of the with the calibration problem with the flow channel. So, I always try to start marking the line where I actually give the start the study. So, I mark it with either a line or a plaster or a needle, and then I know that I actually started there and that much has gone. It is not an error in the computer which is calculating. So, it may also be because we have delayed the procedure too much. The patient himself produced a lot of urine before we started the study, or we did not empty the bladder properly. So all those things can be the reason for the volume not adding up. So now when you come to reporting the UDS, again you have to think what you came looking for. So you have to report a urodynamic study accordingly. You have to report the filling phase and voiding phase. In the filling phase, you have to tell about bladder function, whether the detrusor is normally active or overactive or underactive, whether the detrusor sensation is normal or increased, reduced or absent, whether the bladder capacity is normal or high or low, and the bladder compliance is normal or impaired or poor. Then you should also be able to mention whether there is any leak during the study which is not associated with the bladder contraction. So that may be because of a sphincter. Then in the voiding phase, you should tell about the blood detrusor activity, whether it is a normal active or underactive or reflexic, and you should also be able to tell whether the sphincter is not contracting during the voiding phase. So compliance is a derived value. Derived value means you don't get the compliance visible, but you can, it's basically the formula of compliance is delta V by delta P. So if you start here at a pressure of 0, and then after a 300 ml fill, you have pressure of 30. So you have a delta V by delta P of 300 by 30, which gives you a 10. So something like a 10 is a moderately impaired compliance, because in a 300 ml fill, you are not supposed to have a pressure rise of 30. So that is what it means. So if the compliance is impaired, that means poor compliance, severe compliance, that means the slope is high. The pressure is going up. from 0 to 30 or 40 before the fill means the compliance will invariably will be a poor compliance or non-compliance. So that is how it is. The compliance is inversely proportional to the slope. Unstable contractions are the contractions which you see during the filling phase, and it may be associated with the leak. If it may be not associated with the leak, but so this is something which you have to report during your reporting. And sometimes the unstable contractions happen so frequently that they mask the poor compliance, and sometimes there is an unstable contraction and a poor compliance. So that is an unstable contraction with the non-compliance. Despite the leak and then contractions, it is going up very highly. So this is a non-compliant bladder which is going up, the pressures are going up very high at the beginning, and then after the augmentation it has become stable, the pressures are remaining in the flat line. Now this is a patient where the rectal line kept slipping out. So that is, if the rectal line keeps slipping out, what happens is suddenly the P det goes up. So you have to be aware of what has happened here to note that this is what is the thing which is happening here. Now whether you can do urodynamics without a rectal line, I will not recommend it. But in some patients where there is a severe rectal incontinence, also rectal sphincter is also gone, you may have to do. But as I said, you can indirectly look at it. So if you look at this curve, this is pretty much flat. It is not rapidly rising, so the compliance is okay. If you look at contractions, these are acute contractions which are like a cough or some crying, but there is no smooth contraction waves like a unstable contraction. So if you know the principles of urodynamics, you can tell even without a rectal line that this particular study is normal. So in this particular patient, there is a lot of post-void residual, and so this is how the bladder looked. So the bladder looked abnormal. Now the urodynamics can be false negative in patients with a large bladder diverticulum, in patients with the bilateral gross vesicouretic reflex, or if the patient keeps on leaking out. So if they keep on leaking out the urine, then the pressure doesn't go up, or if there's a large diverticulum, again it doesn't go up. If there's a bilateral reflux, it doesn't go up. Then you have to tell in the report that this pressure did not go up, but we know that the patient has got bilateral grade 5 reflux, so you have to take it with a pinch of salt. So this is a 9-year-old girl with the sacral agenesis, and that is the normal looking study, but her bladder is so bad and her reflux is gross. So you know that this is not a normal UDS. You have to report it. You have to mention that this is the problem. And the voiding phase, as I said, it's very difficult in children. In this particular patient, the voiding phase, that he did not generate adequate pressures. We have actually put a EMG graph also in this patient. EMG electrodes are put. This is a patient where good voiding pressures are generated. During voiding, the pressures go very high. So that is a good contraction. So this is a good voiding pressure generated. There are various voiding phase indices. I'm not going into this because in children we rarely use this. Is more important for a voiding phase in an adult, where you have this bladder contractility index and bladder outlet obstruction index. These voiding phase indices are very difficult to obtain in children. Urodynamics via Mitrofanoff. If there is a Mitrofanoff, obviously we do urodynamics post augmentation to assess the capacity of the bladder. Now uroflow, typically the uroflow is used in a child with the post-urethral valve or hypospadias, mainly to assess any obstructive uroflow. If you put the EMG lead in a child during uroflow, you can assess the voiding dysfunction. This EMG lead actually is looking at the external sphincter dysenergia. And in all neurogenic bladders, as I said earlier, you always get a uroflow before you start the study, because getting uroflow at the end is difficult in children. Uroflow and post-void residual volume are very important predictors. I do not have to stress much on it. You all know that bell-shaped curve, adequate Qmax, minimal PVR, all those things are parameters to make sure that there is no obstructive voiding. The voided volume can influence the Qmax. If the voided volume is too small, then you can have a false low Qmax. A too large voided volume can give a false high Qmax. So you now have the Cherokee nomograms which are come up with the machine. It can give you actually the corrected nomograms. You have to be aware of the artifacts in children, particularly they have to void inside the machine. If they go outside, then you cannot measure it properly. The Uroflow EMG as such can be particularly useful in voiding dysfunction. We have reported our experience on role of Uroflow EMG in children with a low urinary tract dysfunction. This was published in the Indian Journal of Urology. We described 4 different types. This is a normal Uroflow EMG where during the flow there is a good relaxation of the sphincter. This is a patient with a detrusor sphincter dysenergia, where there is a external sphincter is contracting during the uroflow, and this is a tower-shaped uroflow, which is a high Qmax. This is an overactive bladder, and this is a prolonged trace with a delayed deferred voiding. So this is a lazy bladder. So we describe this kind of urodynamic patterns based on uroflow EMG, in particularly in children with voiding dysfunction. Now, what is biofeedback? Biofeedback is a mechanism where the children are taught to unlearn the bad habit like contracting the sphincter. So this child has been connected with the electrodes at the perineum, and this particular child can contract. And if the child contracts the sphincter, external sphincter, the fish opens the mouth. If she relaxes, the fish closes it, something like that. So they go and catch the jellyfish, and then that is how they learn. So this is a active contraction during voiding, and as the child learns it, the child can void. How to relax the sphincter, the external sphincter, the child can learn. So to summarize, urodynamics is an invasive test, and it is used only when it is going to alter the management, and it is essential to be there during performance of the study in a child. And interpretation of the urodynamics is a basic skill needed for a urologist. So I'll finish with that note, and then